And in the future, some of that may change, but I think it's important to recognise that we will never not still do a review into a suicide. And if a family especially has a number of concerns, then we will absolutely still do the full investigation. But there will need to be a shift in culture, because we will need to look at all those other incidents where there may be opportunities for us to learn, but because we haven't focused on them in the past, we haven't, taken those opportunities. We've got some work to do with the coroner, but I understand, that's already happening, and actually the coroner is very supportive of our current processes, but also how we can potentially change them to ensure that the coroner still gets everything they need from an inquest perspective. And also aligned with all of this, because there are different ways of reviewing incidents and doing investigations and doing different methodologies, there comes a lot of training alongside all of this to ensure that our staff are equipped to carry out the correct reviews. So that's all going to take time. And the only way we'll get it right is to ensure that we listen to our stakeholders. So there's a significant amount of work that's going on at the moment to talk not only to our frontline staff, but also our managers, but also our external stakeholders and other agencies that we work with, and also that have input into these patients' care, that we then do an investigation into. So it's important that we bring them on board with any changes that we make. So that was, in a nutshell, the new framework for how we will respond and learn from our incidents. One of the other areas of the strategy is the patient safety partner. So we as an organisation already have a large lived experience workforce that support a number of our teams and services with their lived experience on different projects, on different work streams. Within the patient safety strategy, they ask for people to come and support our patient safety work. So people that have had experience of the NHS to actually come and focus specifically on patient safety issues. So within the Trust, we're fortunate enough to have already found 4 people that are willing to come and work with us on patient safety issues. So we've got 4 patient safety partners already, come from a breadth, depth and wealth of experience of different areas. And the idea of the patient safety partner is that they can help us in different ways, so that it could be that they sit on some of our committees to ensure that the patient voice is heard at that level, or it can be that we go to them and ask for support with some patient safety information that we're producing and making sure that it's in a way that patients, families, etc. will understand. So our patient safety partners, some of them they're all from the lived experience workforce, but as I say, they'll all do different roles, and at the moment what we're working towards is understanding and working out what kind of things that they can then get involved in. And that's not just for the patient safety team to work out, that's for all of our services and teams out there to think, when they've got patient safety issues, how can they involve a patient voice in resolving them or discussing them. So alongside that, I say, is also our work with our Making Families Count. And also we're fortunate enough in this organisation to have a family liaison officer. So her responsibility is to work with our families who have been bereaved, often through suicide, to ensure that they get the right support, to ensure that they're signposted, but also to ensure that they understand the alongside investigation that we as an organisation are doing, and the flow will work closely with our patient safety partners in the future to understand, as I say, from a family and patient perspective, how best we can utilise their desire to work with us and their skills. Thanks, Dan.
Okay, thank you, Helen. So yeah, the next significant thing of note, which I wanted to talk to you about, is around the patient safety syllabus. So this is the first time that there has been a national standard around training in patient safety, which really kind of sets out how we do learning from patient safety in the NHS. So there's a number of levels. I'm not going to go through each of them, but broadly speaking, we've got level 1, which we've agreed in the Trust to be mandatory for all staff. and Helen might have an updated figure, but the last one I had was around 75%, which is absolutely amazing. And we've actually had some really good feedback on that. Quite straightforward training, but it just sets a kind of minimum level in terms of people's understanding of patient safety. And all the levels up then in terms of who is required to do them depends on role, and obviously the more patient safety or governance focused role you're in, the higher the level of training people are expected to do. So that's really the syllabus overall. LFPSE, which I mentioned earlier, so this is all about our incident reporting system and how we get our data. Now LFPSE replaces another national system, and the idea behind this, it's led by NHS England. The idea behind this is that they have better use of high-level data about services that were provided. So they want some consistency in what's being reported so they can do thematic analysis and that type of thing. Now, we're working with the team on that. It will impact our DataX form that we've got, and we're just working through exactly what those challenges are at the moment. And we've got several meetings and routes to feedback on the fact that will change the form for us. It's probably our greatest risk actually with the strategy in terms of our concerns that it might lengthen the form and perhaps make it less mental health specific. So we really are pushing back very strongly on that to the national team, finding whatever routes we can with that, but at the same time really thinking about how we can minimise any impact on our staff once it goes live. And that's the end of our show. So that's the main things that we'll focus on today, and happy to take any questions about anything else we've not covered.
Right, thanks so much. Just see if I can get back to where we are. There we are. Tom. Okay.
Yeah, good morning, and thank you, Helen and Dan, for a great presentation. Since I was the person that asked for an update at the end of last year, I thought I could take a chance to speak first. There's a couple of points I'd like to make. That I think that the fact that we have a QI program is going to greatly assist our ability to learn from safety incidents. They really are going to go, join together and make it much easier to, change process, especially with, the input on any process changes from the, from the staff at the front line. So I think that's brilliant. I'd love to see a copy of the slides, please. You mentioned the learning culture, and I was just going to broaden into that a little bit. That I used to work in the aviation industry, and it is actually transitioned now from just culture to fair culture. And the idea, part of the idea is this, that just or fair culture doesn't just apply to safety incidents. It needs to apply across the whole part. Anything in the trust, from HR to anything, that people, you can't say I'll treat people fairly when there's a safety incident, but other than that, I'll just do what I want. So I thought that just mentioned that to something I was reading the other day. The other thought, and I haven't thought this through yet, I just wondered if it would be an idea to invite one of the patient safety partners to the governor's quarterly quality review of complaints and incidents. We might learn a lot from the patient safety partner about what's happening, and they will learn a lot about the type of complaints and incidents and what the governors and as representative of the public might want to know. So perhaps an invitation, but I just came up with that. I have not thought that through yet. The other things that I would like to know a little bit more about is the duty of candor and all of that that's going to be involved when you're dealing with the family and the establishment of a single point of contact for the family when there is a really serious investigation to be carried out. But I'm very pleased to see that the trust is doing so much in this respect. I just add at the end that I happened to be from last December, a patient safety partner myself at Cute Hospital in London. So, and if there is anything I could do to, if you wanted ever to talk something over with somebody that's involved at another hospital, a Cute one, and how they do things, I'd be happy to help. But thank you for a great presentation.
Thanks, Tom.
Tom, just before we go to Tom Lake, Dan, would you be able to say something about duty of candour?
Yeah, sure. I can just, if I can I just pick up the points that Tom's made, because they're really useful points. So duty of candour. So duty of candour isn't affected by any of these changes. So duty of candour will still apply to patient safety incidents where people have come to moderate harm and above. So that will still apply, Tom. The actual thing that this really brings is that there's groups of people where moderate harm hasn't occurred, but perhaps something quite distressing has happened, that at the moment we may reach out because we're pretty good at that stuff, but there's nothing that makes sure we do. This will build on that, so I think it will strengthen it. The safety culture stuff, now I'd be happy to come back or to talk to you about that, but I completely agree with you. This isn't just about patient safety, and we're really far forward of our safety and culture in this organisation. Debbie, our Director of Nursing, chairs our safety culture group, but to illustrate your point, that's attended by our medical director, by our HR director. It covers a lot more than just patient safety, because all those things need to work together, don't they, to be able to get the culture we want. So I'd be happy to come back with more detail on that in terms of different pieces of work that we've done. QI program, I just completely agree. We're in a great position. We already have our True North goals, and we've got really clear mechanisms about how they permeate down through the organisation, and it's around just taking another step forward for us so we continue to remain one of the best trusts in the country. It would be my comment on that. And thank you for the offer. We will certainly reach out to you, Tom, in relation to your experiences as the patient safety partner.
The only other point I would make is I actually took upon it myself to do the HSIB SEEPS Level 2 course without realising the amount of hours involved in that. But be warned, if you ever think of doing that, your mind glazes over when you say this presentation will last 1 hour 39 minutes.
I think you deserve a medal, Tom, if you've done that, because that's what our patient safety team and divisional governance leads is trying to work through at the moment. And because we found it all so difficult, we've actually asked for it to be delivered face to face. And we're the first trust within Bob. We're doing it across the ICB. We've got 2 days this month for that very reason. So well done, because
that's brilliant. Because asking staff to slog through that is. Yeah, it would be too much. I mean, they would end up to, you know what, I'll just do the quiz at the end and hope for the best.
Okay, well, Tom, thanks for your comments and the response. Tom Lake.
Yes, just wanted to say, put a sort of radical thought in, given that the downstream from this process is learning, the question is, could this process also be taken innovations and changes to work which are positive, where harm is not the focus but improvement is the focus. Now that what I'm just to give a bit of a perspective, what I can see here is that the very serious issues connected with harm are sort of dominating. They do dominate thinking, and if you want to get to the place where you're looking at near misses as well, which I take it is sort of part of it, then perhaps you want to put a counterweight on the other end so that near misses aren't the end of the scale. And so broadening the whole perspective of this would be to include innovations and changes of improvement changes, might emphasize the learning that streams down, the downstream learning, and just add as a little bit of a counterbalance to the very necessary constraints of and things that procedures associated with the harm side. Thank you.
Yeah, thanks, Tom. So Yeah, I completely agree that, and that's a key principle of what we need to change. So probably the best example is the one Helen touched upon in relation to discharges from other hospitals into our services. There's a huge amount of learning that will improve patient experience and safety there. Doesn't really touch us very often because it doesn't normally result in significant harm at the moment. So we need to focus on those types of things instead of just the harm incidents.
Dan, Helen, thank you very much indeed. I think this is really important as far as I can see, because it does get to the point of two things. One is real engagement with all parties that are involved, you know, as open a way as you can, and also getting underneath the detail of a particular incident to understand the generics. And I find it very interesting following the very distressing maternity deaths that occurred, you know, at Morecambe and East Kent, etc. And the East Kent report, Bill Kirkup, I think, did it. You know, it was saying that he got fed up with writing detailed reports on what went wrong, but rather we need to understand what are the underlying issues that are causing these to happen, and these may be quite general issues rather than, you know, the detail of the actual incident. So I think we're getting a much more mature understanding of how to prevent harm and what we do about it if it does happen.
Yeah, Martin, the systems engineering initiative for patient safety is the kind of framework that's put out as a systems engineering side covers all of that stuff. It's actually, the thought behind it is very, very good. Yeah, as an ex-systems engineer, Tom, I couldn't agree more. Okay, well, thanks so much, Dan and Helen. It's really good stuff, and we look forward to hearing more in the future. So thank you very much indeed.
Yeah, thank you for having us.
Thank you for having us.
Okay, we'll leave you there.
It's a pleasure.
Thanks, bye.
Yeah, thank you.
And I think, Julie, we could arrange to have those slides sent round, couldn't we? To
yeah, no, absolutely. I'll send
That's
those
fine.
round today.
Oh, thanks. Okay, well, that's very interesting, I thought. And now on to item 6, bite-sized learning. I don't know if we have to do an exam at the end of this or not, but
there might be a pop quiz.
There might be. Okay. Understanding performance reports. Ian Hayward, Assistant Director of Performance and Information. Ian, over to you.
Thank you very much, and thanks for having me. I wasn't quite entirely sure of the brief, so I've kind of mixed up the Council of Governors performance report, which is quite small and light for your edification, and then the Quality and Performance Executive Committee's rather more significant performance report. So I'll just share my screen. As Dan was saying earlier, if you've got any questions, just pitch in, because I probably won't be able to see your hands. No, I definitely won't. So I'm Ian Hayward, Assistant Director of Performance Information and currently Transformation. I've looked after performance since 2013 in the Trust. I've got a team of 2 that also look after benchmarking and other performance reporting. And performance in the organisation follows a QI methodology, which is around board to floor. So we've got reporting at different 3 to 4 levels within the organisation. So there's a board report that the Quality Exec and Finance Improvement Committee get. So I've not got a picture on that. I just thought I'd try and explain where it is. Then there's a divisional performance report, and they tend to funnel outwards the further down the organisation you go. And then there's unit or team level or ward level performance reports, and those meetings happen at different times throughout the month. So in theory, the updates percolate up through the organisation. So I think that was enough for my preamble. Now this is stuff you already know, but I was just trying to summarise the governor's report as opposed to the wider performance report within the organisation, and the ones within your report are the key metrics, either nationally or regionally, the ones we really need to focus on and worry about as an organisation from an external perspective. So for me, they're the ones that we haven't got a choice on, that we've got to look after and manage. Within the wider one, you'll see there's a lot more focus on quality, staffing, and other domains, as we like to call them. And within your report, they show the latest nationally available figures. And unfortunately, national, as you can probably imagine, it tends to be a little slower in publication. But these are the latest we've got available. And you know what details you've got in there around here, but I suppose I'd just point out we call it RAG rating, so red, amber, green, but as part of our QI journey, we eliminated amber, so it's kind of a pass-fail these days. And these are all the abbreviations and acronyms. I can explain any of them, but within your report you get the a little bit of definition, which is that one. So it's quite nicely laid out for you, and it gives you a little bit of detail. So the trust performance report, we don't get that level of luxury. So if anybody's unsure, then I have to try and explain it to anybody.
Ian, are you sharing the screen yet? It just.
Oh, I thought I was.
I can't see it myself.
Oh, but, my apologies.
Yes,
I can.
Yes, I can see it. Yeah.
Oh, okay. It must be just me.
I can send it to you privately.
No. I've got the slides in the paperwork.
Okay,
that's all right. I just okay.
So that was the Council of Governors report, which I hope was a good whistle stop. There we go. So the quality executive and the board performance report aligns to our annual objectives and plan on a page. So they are continually changing and shifting, and we take input from any of the national indicators that change or get better definitions. As I said, it follows the QI methodology, and we've got 43 trust metrics and 53 currently compliance metrics. Yes, thanks, Tom. It is a bit of an industry, unfortunately. So that's NHSI. Well, pick a vowel, really. Whoever the current vowel of the organisation is that's looking at us or after us. So it doesn't feel like we've got too much room to manoeuvre by trying to keep quite a lean performance report when there are so many national objectives. We've got 4 different types of indicators. So we've got a breakthrough objective, which is the ones we really want to focus all our muscle and energy on. We've got the drivers, which are the main key indicators. We've got tracker ones, which we define as mainly they're the national objectives. So if they go off within a month, then we need to take some action. And then we've got trackers, which are ones it's a bad term, but we watch. There are business rules to dictate our behaviour as to what we do at certain points. And we've also got some statistical process control charts now to give us a little bit more detail, and I will show you one of those in a minute. As I mentioned, we've got the 4 domains that you're probably well familiar with, which is the harm-free care, patient experience, supporting our staff, and money matters. But then we have the inputs, as I said, from the outside. So we've got regulatory compliance, which could be any national targets that aren't contained within the 3 underneath. So we've got an oversight framework, a system oversight framework, and that makes life a little complicated because, as you know, we're part of 2 systems. So we have to split those out, and then we've got the long-term plan objectives within the NHS. So this is it's a bit small, so my apologies, but it was just for illustrative purposes, so I didn't put too many words on a slide. But our breakthrough objectives and our breakthrough objectives, we've got a lot more detail for the organisation to review. So this is called a run chart. So basically, it's a line. There's a line in there that shows a target and our current month performance. We go back 5 years so that we can get a good indication of the trend of where the indicator's going, and then we also get a bit of detail and breakdown as to what happened in the month. This one happens to be falls, and this shows us by each of these little blocks is a particular ward where falls were happening, and because we take the data directly from Datex, our instant reporting and other things system, we've got where those falls were occurring, so it gives us quite a nice amount of detail. The breakthrough objectives, which I've mentioned, get a stand-up section. So metric leads give us a presentation about where it's going, future actions, what's going on within those, and then we've got the other objectives within the performance report. And I think I've probably covered this now, really, but we have a set format for how we go through the report. So I usually start off with the driver metrics, so the important indicators that the trust has chosen. Then we have it's called a virtual stand-up, which Julian does quite well because he is actually standing up, but most of us are sat down at this stage. In the good old days pre-pandemic, we were all in one room and we all used to physically stand up and look around some charts on a board. But obviously we've got far more efficient these days, so it's all done electronically. But the leads present a presentation around their indicators, and these are the breakthrough objectives we've got for this current year. And I won't read them all out for you. And then by exception and by business rule, I run through the rest of the domains. And I think that was my presentation, if that gives you a little bit more detail as to what we do around performance.
Yeah, and thanks very much.
Silence.
No, I'm just looking at the pack.
Oh,
remind
fantastic.
myself, you know, that's only to impress Julian that I do read his stuff, you know. So it's right, but I mean, this data, the data we have is really important to, you know, we get it right and it's meaningful, and also that it's easy to assimilate, because, you know, if you look at some data packs and some trusts, that there's a lot of data, but it's very difficult to sort of deduce what it means and whether it's being considered at the right level. And I think that the executive has done a great job on this data. But I'd very much welcome any questions. Tom Lake.
Well, just to say, it's really a comment, just to say that we look at harm-free care, but we don't look at harm-free and effective care. Now, you might say there are many areas where it's difficult to measure that objectively, but then in the patient experience side, we don't ask for effectiveness. So we ask a lot of questions of patients, but we don't ask, was our care effective? So that is, to my mind, the big lack in the performance report. But lots of good stuff, I know.
Julian.
Thank you.
Julian, you there?
Yeah, just trying to work my mute button. Sorry, Martin.
Go on.
I think it's a very good point that Tom makes, but it's not a point that we're not cited on. So services do generally ask patients and do assess outcomes. For example, IAP's a classic example where we can actually compare it nationally. So the issue is, Tom, is that most services have slightly different outcome measures. Because you know, outcome measure in physiotherapy is quite different to that in early intervention in psychosis, where again we do kind of measure those things. So it's quite hard to produce something that is digestible for the board at the moment in the absence of a national thing. So if you take what we're going to look at in a minute, the patient experience tool, we also had many of those. So we actually created a single patient experience tool, so the board could at least give a helicopter view of what's going on, and then we can drill down by teams. It's much more difficult to create a single outcome measure that clinicians and patients are happy with. In fact, I can tell you, because we did research on it, nowhere in the world has actually yet cracked that. So I'm completely agreeing with you. You know, not only should people have a good experience and not only should we not harm them, we should also make a difference in terms of the care. We can report that at individual service level, but more often than not, but we are struggling to do that corporately. But it is the holy grail and one we will continue to work on.
Thanks, Julian. Thanks, Tom. Any other questions? Okay, in which case, Ian, thank you very much for the presentation. We look forward to next month's pack.
Thank you very much indeed, and nice to meet you all.
Okay, thanks.
Thank you.
Yes, thanks so much indeed. Okay, we could move on to committee steering groups, item 7. So we do living life to the full first. I've forgotten who chairs it now.
Sorry, yeah, that's me. Can I do it second? I've just got to bring up my report. Sorry, I'm a bit.
That's okay.
I should have had it up, but it's not there on my screen. Right.
Shall I make just a couple more comments about membership and public engagement, Martin?
Okay, do that, and then Tom,
Yeah.
when Tom's ready, we'll.
Yeah, very briefly. In terms of the meeting was fairly late in the calendar, so that's why there's not a full report in the meeting papers. Just a couple of points to add. Marcoms are doing an excellent job, as always they do, on the PR and information that they put out in social media. A couple of meetings ago, they agreed to put out something on membership once a quarter, and 2 of those social media posts have gone out on Facebook and Instagram. And at the meeting, we asked if that frequency could be ramped up in the run-up to the governor elections season in late spring. And also taking an action on myself, I'm looking at a small project to look at a second channel of approach to targeting membership where we are down on numbers in things like diversity factors. And that campaign is likely to be an email-based one. It's in its early stages of discussion at the moment, but clearly I can present more of a paper on that next time round.
Thank you, Brian. Perhaps I could just add on this before you invite Tom back, that Julie and I had a very productive meeting with Catherine McDermott, who leads the health inequalities work in the Trust, on this issue of how do we reach communities that we don't currently reach very easily. And Brian, we'll come back and talk to you about that, but I think we've got a way forward, which sounds very positive and all encompassing, if I put it that way, rather than doing little bits here and little bits there. So that was a very helpful discussion with Catherine. But as I say, we'll come back when we next speak. Tom, are we ready to go? Or? Okay, Tom.
Thank you very much. Well, Living Life to the Full met on the 22nd of February, and we were continued looking at the pathways that cross the sort of organisational boundaries of the Trust. So this one was a really interesting presentation on the Long COVID service, which is a clinic that's jointly run between Royal Berkshire Hospital Trust and ourselves. So we had a presentation from Genova Burton and Lisa Leighton. So they're really interesting. Of course, this was a complete unknown when it appeared later in 2020. Long COVID is where COVID symptoms persist after 12 weeks, and there's a huge range of symptoms and a huge range of acuities, with some people really severely affected over long periods. So great uncertainty when this started. So absolutely everything to learn, and when they started out. So it was clear that the acute hospital on its own couldn't provide the range of rehabilitation that patients needed. And when it was tried, it was found that they didn't respond in the right way to the normal rehabilitation because of the fatigue issues that these patients have. So there was a lot to learn, and eventually a pathway has been devised, starting with assessment at the RBH and then going on to rehabilitate a great variety of rehabilitation and psychological services that are available from Berkshire Healthcare. So there are lots of, as you can see, this kind of collaboration. I mean, it's brilliant. They were innovating. They were working together under extremely difficult circumstances at the time. Unknowns, GPs not knowing really what to do and how to refer, what to do, what to advise their patients. So GP education is a big part of it as well. So all of this going on. So the issue is, of course, funding at first. The initial funding goes to the Royal Berks, but Berkshire Healthcare has an agreement to draw down, and that's negotiated. But as this was unknown, it must have been stressful to try and elaborate the whole thing. There's joint clinical governance, so that's another thing that happens. And then the IT issues are difficult. The clinicians are sometimes having to use 2 laptops because there's no basis for collaboration at this level between the 2 trusts. And that's the sort of thing which would require real national infrastructure, I think, because it's similar to the GP infrastructure that underlies the NHS app to interface to completely different supplier applications and get some common access. So just to say that it was very instructive. As often occurs, the staff were very impressive and really, really interesting presentation. So that was our presentation on the 22nd. We meet again on the 19th of April, and we'll be looking at the environment that community mental health teams have, especially where we'll hopefully Reading, look at the Reading example and see what's happened with now that social work and mental health have been separated and things have settled down. Thank you very much.
Okay, any questions for Tom? No? Okay, shall we do on the quality assurance meeting? So,
Well, Paul sent his apologies, so I don't know if anybody
cool.
else who attended the meeting can say anything, or if there's any questions on Paul's report, we can take those back.
No, I think we'll probably wait until next time and then pick them up then. Thanks, Julie. Okay, could we move on then to item 8, executive reports? The first is the patient experience Q3 report. Unfortunately, Kim Delman has had to unexpectedly go somewhere else today, so we've got no one to present. But if there are any sort of comments or questions, and maybe Julian might be able to address some of those. Tom.
All right. So just about the graphical presentation, after about a year of looking at this, I realized that these grey areas at the left hand, on the left of some of the bars, and I believe these indicate don't know or no answer. I'm not sure about it, but I think that's what it must mean. And if that's the case, it's not appropriate for them to be presented this way, because what it means is we can't, the percentages that we're seeing and the graphical presentation of them anyway is not giving us a fair view of how good or bad this particular answer is. It's just telling us more about whether people answered it or not. So it just isn't the right presentation. You could put a little indicator to the left or something to say there were more don't knows here or not, but it just doesn't work this way. This is not the right way, I think. So just making that point. Thank you.
I'm not quite sure I understood that, but can you? We might want to take it outside, Tom, if it's a detail.
Yeah, okay.
But is that all right?
Yes, I'm happy with that.
Not happy with that. Shoulders, but
yeah, happy to write a little note
okay.
and to then see where we go with that. Thank you.
Right. Thanks, then. Brian.
Yes, just a quick one. In the spreadsheet of data on complaints, there's one, I think its number is 8700.
What page, Brian? Are you on the pack?
The page is a 46 in the meeting papers. There's a complaint there that's been escalated to SI level. So my question was just procedural. At what point in the timeline will that be reported on to governors? Because I think it's only gone to a serious incident in more recently.
This is page 46 of the pack.
Page 46 of the pack.
And can you give a specific, because there's lots of.
Yeah, it's 8700. It's, let's see, 1, 2, 3, 4, 5. It's about the 6th one down.
87.
To do with district nursing in Wokingham.
Correct. Let me. Brian, the question being that now that's that complaint, once it is looked into, we recognise that we've got things wrong, so it goes into the process that we just had a presentation on, and so that will then go into our board presentation around, serious incidents once it's investigated.
Right.
Does that make sense? So obviously, yes. Majority of complaints will just go through the complaints process, but in a way, there's some assurance here, isn't there? When we get a complaint and think, oh gosh, actually, this isn't just a complaint. There's a serious concern here. It then gets escalated so that Debbie, the director of nursing, and Minu, the medical director, now start to take oversight and do a fuller and more comprehensive investigation, which goes through that serious incident framework, which then also has a sort of governance structure to it in terms of both reporting to the board in terms of outcomes, and also, as you heard, working with the family as well. All that sort of procedure kicks in. Does that sort of make sense?
Yes, that's absolutely what I was looking for. Thank you.
Okay, thanks, Brian. Good spot, by the way.
Tom, have you got another question, or is that?
Yes, just to say that complaint 8668 appears twice, So I just don't know how this was put together, just to keep people on their toes.
Okay, that's fine. If there's nothing else, can we move on to the performance report from Julian?
Martin, as ever, it's probably easier if we just take it as
Yeah.
read, because I can never predict what kind of questions come from this. So let's just open it up, should we?
Let's do that. Any questions? Guy?
Yeah, hello, thank you. I've got 3 concerns, please. Firstly, is the out of area bed days are very high, higher than target. Also, the recruitment process is 91 days compared to a target of 55. And also, as ever, I'm always concerned about the number of assaults on staff. It's 165 in that quarter. That's 2 a day, almost every day. And I know despite our best efforts, it doesn't really change. So I'd welcome a sort of deeper conversation, maybe a presentation from somebody who's closer to the ground on what's happening there, please.
Okay, just before I invite perhaps Julian to respond, could you just take them one at a time and tell us what page in the pack, so we'll make sure everyone can focus on the same thing?
Yeah, so let me pick up the out of area placements for those people who are not familiar with this. This is inappropriate out of area placements where our hospital, Prospect Park, is full in terms of adult mental health care usually, and it's normally general adult acute and psychiatric intensive care units where we have a shortage of capacity. And what Guy is saying is, look, the numbers are still high in terms of the people sort of going out, and we know that's not good for folk. So there's a couple of things around that. Certainly, post-pandemic, we have seen an increase in presentation of people with acute and serious mental illness, including people not known to us. So that's one of the biggest sort of trends that's happened. People completely unknown to us. So that's created an additional piece of demand. We have, because there's a time lag in terms of the presentation of this and the sort of quarterly view and the current view. We have significantly reduced them over the last sort of couple of months, so we're in a better position. But we've also done a bigger piece of work, which is going to be presented to the discursive board next week around bed modelling and answering a fundamental question: is do we have sufficient numbers of beds given the demand, given the change in population, etc. And we think we are probably about a ward short, Guy, in that we think our wards at Prospect Park are too big. So there's we need to shrink those, and that creates some additional need. And we think we're probably about 10 beds short, even if we did nothing else. So we presented that information sort of at a high level, just like I have done to commissioners, but we'll be working with the board now about our next steps. So that independent piece of work that was done was predicated on us having outstanding and very efficient and comprehensive community services, and would still have a low bed base by national standards, and by international standards, extremely low bed base. So we'd still be very efficient even if we increase the bed base. But there is a piece of work now suggesting that we probably need to look at our overall beds, even if we are efficient and managing those out of areas better. So there's a sort of longer term piece around that. Recruitment process, absolutely. I mean, there was just 2 elements to this, Guy. It's counted both how efficient the process is itself, but also how long it's taking to get somebody into the organisation. And that's symptomatic of the market conditions at the moment, where it's extremely difficult to recruit to some sort of key posts. What we have done and where we have made a difference is in terms of the internal recruitment process, where we really did have some gremlins, and we had staff and managers expressing quite a bit of frustration around 6 months ago around our own internal process, which was we'd lost our way with it. So we have certainly improved that, and we've introduced intelligent automation, which you had a presentation on actually, governors, last month to help with some of the administrative flow around that. We're working obviously to try and reduce that. Assaults on staff, you're right, and I think it would be a good presentation, Martin, Julie, to have, because we if you go back to Ian's presentation, we home in on that every month, and we do a little bit around that. But just to give you a quick update, we count every assault. So say if on the learning disability unit, if someone was to push you 6 times, we count that as 6 assaults. A lot of trusts only count that once, but actually if you've been pushed 6 times, you've been pushed 6 times. So our numbers are quite high, but we think that's the right way of doing it. About 50% of trusts count every assault. They're often concentrated on 1 or 2 individual patients. So patients predominantly have high numbers of assaultative behaviour, which is quite difficult in the early days to address. But actually, it does suck the joy out of work for individuals. So it remains a very important piece of work. And if we were to present to you, you'd show that over the last few years, we've tried all manner of things and continue to try all manner of things to reduce that. So very happy to present a little bit more on that. And I agree with you, it's a concern. We don't come to work to get hit or abused.
Thank you. Sorry for all the questions.
All 3 great questions.
That's fine, Tom and Guy. Thanks so much. Any other questions for Julian? Okay, thank you very much, then, Julian.
Sorry, can I just come in there with a question?
Oh, please, yeah.
I don't know if I've mentioned this before, but on the risks related to the risk summary, and I'm concerned that the new MHICS service overlaps the additional roles that GP networks have got. For example, we've got social prescribers and link coordinators, and we've got, I'm just a bit concerned that it is very unclear at the moment. It's a difficult landscape to understand.
Yeah, I would completely support that. So again, perhaps helping other governors who are less close to this is what we've got already, even before these new roles, is a plethora of community-based options. Some of them more generic, some very specific, like early intervention in psychosis or perinatal. We're then seeing some welcome developments at sort of primary care level. So additional roles and responsibilities with mental health directly in GP practices. And I think we've had a presentation at Governors around what we call the mixed teams, sort of the mental health in community, which can look after severe mental illness, but based at primary care level. That does present a very confusing picture for patients to navigate. They can get bounced around very easily, and they're getting multiple assessments. So we've got a programme now called One Team, which we'll be able to present on in the near future, about our vision, about how we can pull all this together and make sense of it. Because at the moment, Tom, I'm with you, although each individual initiative is welcome, the collective whole is a confusing landscape, both for clinicians and for those potentially wanting to receive help. So yeah, there's some transformation work to do. What we've seen is incremental growth of worthy national developments, but they've not been harmonized or coordinated in a way that makes sense. In fact, often they don't make sense at all. So we're on it. It's not an easy piece of work, and I think you'll enjoy a presentation in due course from Jane Reynolds. I suggest sort of the summertime to explain exactly our approach to this. We've been engaging with clinicians and patients for about 6 months in terms of building kind of what the picture might look like.
Thank you, Julian, and thank you, Tom, for the question.
Many thanks.
I think it is a big issue, not just in this area, but this fragmentation and, they say lots of worthy initiatives, but they don't always come together in the way that we would like. There's a wider philosophical issue about the NHS. Annual plan on the page, item 8.3. Any questions for Julian?
Yeah, can I just set some context, Martin? Because again, we've got new governors. So we have got such a diverse organisation. We've got some people working in psychiatric intensive care. We've got some people who coordinate care for people with learning disabilities, end-of-life care, physiotherapy. So, and then we've got a lot of colleagues who provide essential support functions in HR and everything else. So what this annual plan on a page does is give context to the things that are important. It doesn't necessarily always give a level of specificity. What we do in February is produce the plan on the page. And then between mid-February and the end of March, teams look at this as guidance and develop a very specific and smart plan associated with their area. So, for example, physios may look and actually set a clear target around their feedback, for example, and what they're going to do with it and everything else, and set the number and value. So this then at team level does start to get quite smart and gives people quite direction. But clearly, if you look at it through the lens of all the different teams, some things are more applicable than others. A couple of highlights, because this is very much evolution rather than revolution. Some things have been in for a few years now, but a couple of things that have gone in here is on harm-free care, we're really doubling down, and we had a conversation a little bit earlier, Tom, around waiting times and harm as a result of waiting times. So that's sort of gone in, and we're also flagging the necessity for face-to-face care where it's clinically appropriate. We're not trying to say stop doing virtual care because it's very important, but recognizing on a risk basis, sometimes face-to-face care is very important in all settings, from primary care right through to specialist care. On good patient experience, again, we've got weights there, but the one that's new is we will make every contact count by offering advice in making healthy choices. So that it's a recognition that when we have somebody in the room and we might be talking to them about their leg ulcer, we can also talk to them about smoking and other things. So using the opportunity as a health professional to address health inequalities at the same time as that appointment, and really sort of getting that message across. And then on supporting our staff, you've had various presentations on our workforce situation, and there's a very clear message, I think, to colleagues about we will attract and welcome school leavers, because we often haven't, have we? You know, we've often got to think about the profile of our, so really reaching into schools, students, and international recruits and apprenticeships, because we see those as kind of vital areas, and there's been a bit of reluctance sometimes in our organisation to kind of reach out and embrace those groups and support them. And then it used to be, the fourth one used to be money matters, and it's changed to efficient use of resources, because it recognised this isn't just about cash, it's about the environment too. So that's the context. Teams have 6 weeks to look at their last year's plan, evaluate how well they did against it, look at this year's plan and develop their own team plan. And then between April and the end of May, every single member of staff in post for more than 6 months has an appraisal and sets their objectives for the year based on their team plan. Last year, 98% of all staff had an appraisal. The remaining 2% were either on long-term sick leave or maternity leave. And again, the embargoed staff survey puts us at the top for everybody having an appraisal in the NHS. So it's a process that you know, kind of follows through logically and does work.
Okay, Tom, did you have a question, or is that?
No, what I was going to say is that we skipped the CMHT survey earlier.
Oh, that poor chairing, is it? Forgive me.
No, it's part. It was part of the patient experience, Martin.
Oh yeah,
it was part of patient experience. I thought I did have a couple of points, but I thought we were going to take it as a separate item. That's all.
No, you snooze, you lose, Tom.
Go for it, Tom.
Just shall we see if anybody's got any points on the plan on the page first?
Yeah.
Okay.
Guy, can I just ask us? Can I ask maybe Guy or Jane, who are obviously, you know, in a governor role here, but also colleagues who are on the receiving end of the sort of team plan, for any observations they may have, because that's, you've heard from me how it's supposed to be, but we've got colleagues, you know, in teams on the ground who, you know, who have to make sense of this.
Guy, you?
Yeah, absolutely. In response to that, we do indeed. I'm in the financial management and planning department, and we do indeed take our lead for our own team objectives from the plan on a page, the Trustwide plan on a page.
Okay.
Thanks, Guy.
All right. Okay. Tom, back to your questions on the mental health survey.
Yeah, well, there are just a couple of different things I wanted to say. The first is there's one graph of the time changes that's really descending, and that's the assistance with finding work. So it's a bit surprising, because we've got the independent placement service ramping up actually over the period, but that was quite marked, and other people noticed that, and in our pre-meeting we've noticed that. And the other thing is that there's a number of review activities in CMHT that Trust doesn't score very well on. So a little bit below average, that's all. So that was the impression. I just wondered, thought we might spend a moment on it.
Yeah, I think you're right, Tom, about the employment. We have got a good IPS service. There was obviously quite a delay in this, and we did have quite a few vacancies. We ramped up the team, but again, this is a relatively, unlike our patient experience, this is a relatively small sample of the tens of thousands of people we see. But employment, we know, is kind of one of the most powerful things you can do in terms of recovery. So it continues to be a real focus for us, and has executive oversight. Alex Gill, the Deputy Chief Exec, personally oversees the IPS sort of service and makes sure that it's operating, not only offering people, but an evidence-based approach. And there are certainly some things in the CMHTs that are a challenge at the moment. And it relates to the earlier point where the establishment of new teams, Tom, have seen quite a lot of people leave CMHTs to kind of work in those teams, and actually they've been denuded of actually quite a lot of their workforce. So I think community mental health teams are struggling a little bit with some of those regular reviews, and the one team approach is designed to impact on that. The idea ultimately, the one team approach, is we should be able to have support more people, but not in community mental health teams where there's all the kind of formal processes. We should be able to look after more people in the mixed teams, and therefore the CMHT should have a smaller caseload, and they should be seeing people more regularly as a consequence. That's the vision, particularly as the workforce has got smaller, not bigger. So I share your observations and think we've got at least some things in train, but it may take a while before they wash through. But I'd share your observations and agree with them.
Thank you very much. That's very good, and we look forward. I'm sure we look forward to hearing about one team when it comes to maturity.
Okay. Shall we then move on to? Oops, I seem to have lost everyone.
You're having a bad day with the computer. We can see you, and I can see everybody. Something's going on. You've got gremlins.
Yeah, I'm trying to look at something else at the same time, I'm afraid. Jog my memory. Okay, Governor feedback session, item 9. Is there anything governors wish to raise? I've got a few things that might be of interest, but no? Okay, well, I'll just give a couple of updates, general things. First is to note that Pradeep Patel, the chair of Frimley Health, is retired. So he stood down end of last week, I think it was. He was, in my view, an excellent chair of Frimley. We were lucky to have him, and he was very wise and kind man. So it's the end of an era. I've met the new chair. They're not to have much of a discussion, but he seems very positive. So I look forward to building relationships with him. On ICS front, as a member of the Bob ICP, I went to the second meeting of the Bob ICP, albeit virtually, where the strategy for the Bob ICP was agreed. As I've said, I think before, it's a fairly generic strategy. It's difficult to find anything to object to, and the challenge is still going to be how that affects things, in terms of the on the ground, as it were. But that's all going ahead. Julian might be able to correct me on this one, but Patricia Hewitt's review of the integrated care systems, I think, is still ongoing. I thought she was supposed to report fairly quickly, but it seems to be ongoing, as these things often are, a bit like royal commissions.
Yeah, so you have a different definition of rapid than the review does.
Well, when I first spoke to Patricia, because I had a chance at one of the mental health chairs meetings, she was very positive, and she and I had a very common view of what needs to happen, but it seems to have grown into a slightly more bureaucratic process. But we'll see. Let's fingers crossed.
Martin, can I just say on the ICBs, they received a letter last week, which I don't think was entirely surprising to most, but it has come as a shock to some, that they've been written to with a requirement to reduce their sort of headcount and cost base by 30%. Yeah. It's quite interesting because some have already scaled back. So Bob actually has quite a small infrastructure. Frimley has proportionally a much bigger infrastructure, and others, Hampshire, Isle of Wight, even bigger. So if it is a straight 30%, it will lead to slightly different outcomes. But That was announced sort of last week, so that will be another preoccupation for integrated sort of care boards and systems. And no doubt, the Hewitt review will have to take that into account in terms of, because what she's trying to do, I think, is what are the things that ICBs, ICSs should be doing in the future, and if they're going to be right size, what does that mean they can and can't do? Yeah,
I agree. I was going to raise it actually, but that's what I was looking for when I lost you all a minute ago. So I think the thing I think we've got to remember here is that the development of the ICS is sort of adolescent, if I can use that analogy. And there's different approaches, different things being tried, and I think it will take a while before it settles down. I think as a trust, what we've got to do is to make sure that we just get on with delivering with our partners the best care we can, and hope that it all settles down in a way that we can understand and work easily with. But that's, I think, an inevitable when you set up yet another new way of doing business. I've got nothing else. Anybody else got anything I want to raise? Oh, John Wellham, I think, is that?
Yeah. Yes. In relation to the Hewitt review, there's a interesting, in inverted comments, contribution by Boston Foundation Trust, and if anybody's interested in their perspective, then I'm quite happy to forward the link onto them. That's all I'm going to say about it.
Okay, and perhaps colleagues can contact you if they're interested, John. That's fine. Okay, any other business? No. Later next meeting, 3rd of May for the joint Council of Governors and the 14th of June for the formal Council of Governors. So we'll now close the meeting, exclude the press and public from the remainder of the meeting, as publicity will be prejudicial to the